welcome to my one-year progress report. I'm going to talk about uses of CT imaging in acute pancreatitis, severity prediction, and diagnosis of splanchnic vein thrombosis. Shortly about me, I'm a radiology resident at Bajcsy-Zsilinszky Hospital in Budapest and also a PhD student at CTM. And my vision is to advance the understanding and treatment of acute pancreatitis, and the mission is to enhance the diagnostic and prognostic value of CT imaging. These are my ongoing projects. I'm going to talk about them. So starting with the first one, which is titled Growing Risk of Splanchnic Vein Thrombosis in the Early Phase of Acute Pancreatitis. Splanchnic vein thrombosis, or SVT in short, is a thrombotic state of the veins of the gastrointestinal system, which includes the portal, mesenteric, and splenic veins. This local complication affects around 5 to 26% of AP patients, according to recent data, but we don't have prevalence in the early phase, or developmental dynamics are unknown. And we also know that developing this complication leads to further complications. So the clinical question was, what is the prevalence of SVT in patients with acute pancreatitis, specifically in the early phase of the disease? We have employed the COCOPA framework to identify relevant studies. The condition was SVT, context early phase, and population is AP patients. And the prevalence, the hypothesis is that the prevalence is high in the early phase. So using a systematic search and citation chasing, we have found 15 studies eligible. And here you can see the results of the analysis. On this first forest plot, you can see the pooled prevalence of SVT in AP patients in the early phase, which is defined in this context as the first 12 days since symptom onset. The result is expressed as a proportion between 0 and 1, and 0.13 or 13% is roughly means 1 in 8 patients are affected. We have also found really high heterogeneity, with I-squared is 91%, and we have done further subgroup analyses to explore the causes, and we have found several of them. On the second forest plot, or pair of forest plots, you can see a subgroup analysis with the subgroups being the diagnostic timing. On the left, on the A column, you can see that studies that report from symptom onset. On the column on the right, you can see studies that report since hospital admission. And we have found that in the 0 to 3 day range after symptom onset, the prevalence is low, 6%. And at the second group, in the 3 to 11 days group, prevalence increases to 23%. This difference is clinically meaningful and it's highly significant. We can conclude that SVT development takes place mostly after the 3 days after symptom onset, but we also see that almost a quarter of patients are affected after 3 days. On the B column, you can see that on admissions, patients already have a high prevalence of SVT as they delay seeking medical help usually. Figure 3 is a subgroup analysis regarding SVT prevalence with AP disease severity taken as the subgroups according to the revised Atlanta criteria. Here we can see increasing SVT proportions with increasing severity, although this analysis showed no statistical significance. It is most likely due to the low number of studies reporting this. Regardless, this difference is clinically significant. On this next forest plot, you can see a subgroup analysis by AP etiology. And you can see that alcoholic-induced AP patients are the most affected, with 31% prevalence, which is 1 in 3. And in contrast, you can see that biliary patients have only 12% SVT prevalence. This is both clinically and statistically highly significant. On the fifth forest plot, you see a subgroup analysis by pancreatic necrosis extent. And we have found that increasing necrosis is correlated with increasing SVT prevalence. You can see that patients who have no necrosis have 10% proportion or 10% prevalence of SVT, and those who have more than 30%, more than half are affected. So our analysis has many strengths. It was the first meta-analysis on this topic, especially the developmental dynamics were not analyzed before. We have published the methods in Prospero prospectively, and we have accounted for the high heterogeneity in the first analysis. Limitations are that most of the studies included were retrospective by design, and most had low patient numbers, leading to semi-imprecision. So the conclusions are the following. Risk of developing SVT is significant in AP, affecting up to a quarter of patients after the third day after symptom onset. And we have found that alcoholic etiology, pancreatic necrosis, and likely disease severity are associated with increased incidence of SVT. Implications for practice are that screening should target high-risk patients, and we should take anticoagulation seriously in these patients. Implications for research are the following: can it be prevented? And it should be cleared which risk factor contributes more to the pathogenesis of SVT. We have found that alcoholic and etiology and pancreatic necrosis both increase this complication, but there is some confounding between these two, and further studies should explore this in detail. Currently, the manuscript is in internal review, and we plan on submitting to Frontiers of Medicine. About the second project, briefly, we will look at body composition and correlate it with AP severity outcomes. We know that overweightness is a huge global problem, and usually in many cases it was shown that it leads to worse outcomes, and we would like to see if AP patients are affected the same way. So the question will be if CT calculated body composition leads to worse outcomes in regard to mortality, severity, or complications in AP patients, and we will use the GULASH study participants who received CTs. Currently, we have gathered around 500 patients who have a CT scan on admission and on discharge, and the image files have been downloaded, and processing is underway to calculate these metrics. So to summarize, these are my active projects, a couple of months behind schedule, but we will submit them, the first one hopefully in the coming days. And let me finish the presentation by a quote from Nelson Mandela: "It always seems impossible until it's done." Thank you for the attention.
I'm just thinking about the measurement of the higher body fat in the second project. How could you measure it on CTs, just from some slides, or do you have method for that?
Yes, thank you for the question. Most studies use just one slice, but we would like to analyze body composition based on all the available slides, which would be more accurate, I would say. But using just one slice is already a better estimate than just using BMI. But we would like to do more slices.
I'm just curious concerning the second project. You mentioned that you will include patients who have the CT on admission and at the time of the discharge. Did I understand it correctly?
Yes.
Okay, and are you seeking for any change between those, at the positive level? Thank you.
So basically, this goulash clinical trial was not made for this purpose. They were looking at feeding in patients. That was the main goal, to look differences in outcome. We would like to use the image files for analyzing this outcome separately. So this had no effect on the design of the trial, but we can use those image files. Probably there will be some difference in body composition, as being in a hospital is a high stress, not just emotionally, physically, and higher cortisol levels lead to higher body fat and breakdown of muscle tissue. So I guess we will see differences in those metrics for sure.
I have a question regarding the first study. Did all of these included manuscripts identify the early phase as 0 to 12 days, or were there any differences in these?
No, there were two groups of studies. Those that reported from symptom onset and those that reported from hospital admission, and there were very broad ranges. And these groups were the ones we could define to analyze separately. So the first 3 days is usually critical because imaging guidelines say that advanced imaging should be done after 3 days of symptom onset, if there are no major complications or diagnostic questions. So most studies would say that they are before this range or after this range. So it was quite hard to combine them in some groups.